Hello, welcome to Webinar Wednesday on Dental XP. I'm Henry Salama, and today it's a pleasure for me to share a discussion with you on a subject matter that I'm ultimately involved with as a clinician, a researcher, and an educator for more than 20 years, that being immediate loading and immediate provisionalization. And my hope is that by the end of the hour that no matter your experience level, whether you're in a solo or group practice, whether you're a high-tech or low-tech office, that there will be something to take back to your practice, even if it's a greater understanding historically of the immediate loading protocol. For me as a clinician, my initiation and the need for immediate loading as a very important component of implant therapy began in 1990 in treating a patient, as you see here, that was undergoing some significant bone loss due to a failed blade implant, failed endo, fractured roots, decayed roots, and was going to go through extraction of all the teeth, upper and lower in fact, removal of the blade implant and reconstruction of the ridges, bilateral sinus augmentation, and corticocancellous blocks. From a patient management standpoint, and that's usually the decision making in terms of whether to use an immediate loading protocol or not, I wanted to avoid having to utilize an interim removable denture that may actually compromise or add risk to my grafting techniques, even if I remove the flanges on those dentures. So for this patient, I was looking for other options. We fully understood at the time, of course, that Professor Brånemark, in his initial publications in 1977, that to achieve osseointegration in root form implants, that we needed to utilize a no-load healing period. I also, subsequent to that, became aware of work by Leatherman in 1977 and verified by Babish in 1986 of utilizing early loading protocols, 24 to 48 hours with overdentures on implants in the mandible. But it only really became significant to what I did in practice was when I read a great paper by Paul Schnittman and Peter Worley out of Boston talking about utilizing implants to immediately support a fixed provisional restoration in the mandible. Well, I certainly needed that for my case, but I also needed to do it in the maxilla. I expected that would be a higher risk factor because of lower bone quality, areas of augmentation, but nonetheless the patient was duly informed of the risks, that we expected these implants to fail, but we would then subsequently replace them. The great thing is we can then place implants to at least support a fixed provisional restoration and control forces on our ridges and therefore protect our bone grafting. We plan to place 2 extra implants. They were the only areas we could find in the maxilla and in the mandible to support 10-unit provisionals. As you can see on the left part of your screen, we went in, we did autogenous bone grafts to augment both sinuses, and we did corticocancellous grafts to augment the premaxilla. The 2 central implants on your screen were placed directly into the grafts. They would not be loaded, and the 2 distal implants would then be utilized to support 10-unit provisionals. This was done both in the mandible and in the maxilla. And this is what it looked like immediately after surgery. 2 implants, maxilla, mandible, supporting fixed provisional restorations. You've heard of all-on-4. Back in 1990, we called this all-on-2. Not that we wouldn't have taken more implants, but that's all that we could do. To our surprise, in fact, as we went back and placed more implants 6 months later in the posterior maxilla, was that these implants continued to be stable, even measured by perio-test measurements. They were stable. They continued to support the provisional restorations, even as you can see in a biomechanical environment that was really a lot less than suitable. We continued to monitor these implants, and in fact they eventually were deemed osseointegrated and stable and included in the final restoration. This was a protocol that was utilized on other patients, the one on your screen, done in 1991. We used different implants. These were press fit implants, 3 implants would be immediately loaded, 3 would be submerged, unloaded, and in fact, again, all implants, loaded and unloaded, ended up osseointegrating. This was a big surprise to us, and we needed to actually think of a hypothesis that would explain that. It certainly couldn't be explained based on the work of Professor Branimar. Eventually, we did publish on this phenomenon in the International Journal of Periodontics and Restorative Dentistry, and it was actually the first article published on immediate loading of root form implants in the maxilla. The hypothesis at the time that was featured in the conclusion was that in the future that we would be concentrating more not on a no-load healing protocol, but a no overload healing environment. That was the key. Not overloading the interface between the implant and the bone. And we well knew that that interface, especially in the first few days to first couple of weeks, as you see on the screen in the histology, actually undergoes very dynamic changes. There's a very initial phase of osteoclastic activity to remove the debris of damaged bone that was occurred due to drilling and implant insertion. That would create a viable bed for osteoblasts to then deposit new bone, leading to final osseointegration. The issue was that as that gap developed, signified by the red arrows, and there was less than intimate contact between the implant and the bone, the stability of these implants decreased. And we showed this utilizing a graph that you see on the right part of your screen. At the time, in the medical literature and in the dental literature, there was a hypothesis that there's a critical level of micromovement that could be tolerated. It wasn't zero, but somewhere between 50 and 100 microns of micromovement could be tolerated. And as long as you're below that, you could still achieve osseointegration. If micromovement went above that, certainly the possibilities and risk of failure would increase. And you can see that that initial remodeling that takes place at the interface, primary stability is very high immediately after implant placement, but drops significantly over the first couple of weeks. It was okay as long as the implants were not loaded and you gave them enough time to regain bone to implant contact. But if we loaded the implants where that blue line, primary stability, goes below that critical stability level, we would end up with a failed implant and fibrous encapsulation around the implant instead of bone to implant contact. So our hypothesis is that something else is going on. And for the implants that succeeded in our protocol, we had to look at it in a more dynamic phase. Primary stability wasn't the only factor going on, and our hypothesis was that we also had to factor in secondary stability, the evolving biological phenomenon of osseointegration developing over time, increasing over time, and that in fact at any period of time we needed to factor both of primary stability and secondary stability, almost adding them up to what we call cumulative stability. And as long as cumulative stability, even in a loaded environment, kept the implant more stable than that critical level of stability, then we would continue to end up with a successful osseointegrated implant. What would a failed implant look like under an immediate loading protocol? That would be the chart on your right. That's when primary stability and secondary stability, the cumulative stability, adding the two of them up at any one period of time, would actually dip below that critical point of stability, basically having more than 100 microns of movement. So for us, then, anything that we could do to keep stability high, even in a loaded environment, would ensure that we can do immediate loading successfully. We, in many ways, overreacted initially. What we decided was there's many ways to do that. Use more threaded implants, splint them, and we actually used a lot of implants early on in our immediate loaded settings. Dennis Tarnow as well up in NYU, we were using 10, 12 implants to stabilize, make sure that that level of stability stays high. But in fact, it was obvious that that wouldn't be a clinical protocol that would be widely utilized. Not everybody can do that. Certainly financially, it's not possible. So as we took some of these patients through, we then went through that clinical phase and said, okay, now we need to get back. And many of the clinicians involved, Schnittman up in Boston, Dennis Tarnow, our group at the University of Pennsylvania, started to devise protocols and research to really test out these hypotheses. Our group at the University of Pennsylvania embarked on a 5-year study in 1996, looking at immediately loaded implants in the mandible. We decided we'd only do 5 implants. There was a control group that would be unloaded during the healing phase, and the experimental group would be immediately loaded. We used all of this was in the mandible. It was a blinded and calibrated examiner. We used PerioTest to measure stability, and many of the soft tissue and standardized x-rays, and followed these patients up for 60 months, 5 years. All of this was actually published or at least presented at IADR meetings during that period of time. An example of these cases, and to share with you some protocols that were developed for this study that to this day, components of which actually are very, very involved in what we're doing clinically. Edentulous mandible, patient comes in with a denture if it's deemed acceptable in terms of vertical dimension and tooth setup and so forth, we would then utilize it. If not, new impressions would be taken, record bases, occlusal rims, tooth setup would be done, and then we would duplicate that setup or the initial denture. We would duplicate it in both a tooth-colored material to be utilized as a provisional, as well as a clear acrylic to be utilized as a surgical stent. We would then cut out the inside of that stent. We would stabilize it further and make sure it's very rigid, utilizing some braided wires. And we would then reline the area that would be tissue-borne in the posterior with a reline material in the mouth. And we would take a bite registration as well at 3 different points for stability on the retruded arc of closure at the therapeutically decided on vertical dimension of occlusion. Taking this to the mouth, and this was all standardized, all patients received this protocol, except the control group got that protocol 6 weeks after implant placement. We would then utilize these stents to actually direct us in placing the implants. As you see here, the posterior tissue-borne area was, as I mentioned, relined with soft reline to make sure that the area is stable. You can see that even before we started the surgery, we have the vertical dimension of occlusion. We have a good stable bite, and we then went ahead, placed our implants. As you can see here, 5 implants are placed between the 2 mental foramina. And we would then lute the transfer copings to the surgical stent. At that point in time, when you're looking at this, we have the relationship of the implants to themselves, to the stent, and through the bite to the opposing arch. We then added a component by taking an elastomeric impression to give us the soft tissue parameters and shape. Transfer all this to the articulator, fabricate a provisional restoration. As you can see here, this is 1 week healing, and then eventually the final restoration is placed off the same model. Technique that was very efficient, only 1 surgical protocol, usually only 1 relationship impression taken at the time of surgery, and very, very efficient protocol. And our results were that, in fact, between the test and control, all implants osseointegrated. There was no statistical difference in all of the periodontal measurements, PerioTest values, probing depth, attachment level, bleeding and gingival index, and no significant difference of the crestal bone levels. And I think that was obviously a very critical aspect. The only statistically different aspect, that there was a significance in the recession between test and control. There was more recession in the test group, the immediately loaded group, than in the control group. And this is something that we'll talk about later, and why we need to factor that in, especially as we move on to single units in the aesthetic zone. But this difference was really very, very small. It was less than 0.2 millimeters. How do we apply this protocol for many years after this environment? This was our preparation. Here's a standard case in the late 90s that we treated. We would fabricate our surgical stent out of clear acrylic. You can see the space provided. We would realign the posterior area on the soft tissue to make sure that we have a stable environment. The teeth would be extracted and then identify the mental foramina on both sides, because we're going to work between that area. Extract the teeth and level off the ridge so that we can get the dimensions necessary in the width environment to place our implants. Very basic standard protocol that was utilized since the 1980s. We remained about 5 millimeters anterior to the mental foramen. A technique really that to this day for some patients continues to be a very, very viable technique. This is a low-tech technique, but certainly very viable, very precise. You can see that we have both a surgical stent in clear acrylic and a tooth-colored stent that we utilize in the same way. Temporary cylinders are placed on the implants. The temporary stent is then placed over them, and we lute the implants to the stent intraorally so that we can have a very, very passive fit of the restoration on the implants. Do some sutures, interrupted sutures, just to gain a primary closure. We then bring back the surgical stent, or actually the temporary stent, and we lute the temporary cylinders to the stent, and we use the vertical dimension and the bite from the articulator that was, and use the patient's own bite to verify it. And you can see that these are luted with a minimal amount of acrylic. You get a very, very passive fit. It's done intraorally. Then we remove this, fill in the voids, polish it, and we have an immediate loaded temporary, very accessible, very efficient. Same protocol with the surgical stent is done with the transfer copings. Same day of surgery. Take a bite registration in several points on the retruded arc closure of the correct vertical. Lute the transfer copings to the surgical stent. We have our bite registration. Take the soft tissue registration. Everything is then picked up, and all the information necessary to literally go to the final restoration is available right in that relationship that we derived intraorally. This is then taken, the provisional is placed, as you can see here, and the surgical stent is taken to laboratory mounted, and the final restoration is fabricated off of that. Some 6 to 8 weeks later, we come back in and actually place the final restoration. What kind of occlusion do we look for? We try to have an occlusion that has very low angles relative to incisal guidance, and at least one balancing contact on the opposing side. Here is the healing at chance in this case. The temporary is removed, conical abutments are placed, and then the final restoration is placed on top of that. And you can see, even looking at it with the one screw test taken from that initial impression, so only literally 2 visits for this case, a very efficient protocol. We have a very, very nice integrity of the margins even under the microscope. You can see everything is closed, good soft tissue relationship, keratinized tissue, and the final restoration in place. So this was the early protocol for, especially in the mandible. Screw retained restorations were critical, easily achieved in the mandible, and certainly work quite well for us. And whenever we can, I believe screw retained restorations and immediate provisionalization approach is really very, very viable technique, nice and clean. You can avoid any kind of cement issues that may be problematic. It's not always possible, and when you think about case types, as we left that area of immediate loading only in full arch cases, especially in the mandible, we think about where are the other applications in immediate provisionalization. Well, the single unit versus full arch, we're looking at maxilla and mandible, all different. So there's a lot of decisions that clinicians need to go through. Screw retained versus cementable, as I just mentioned. Extraction site versus native rigids. Is there a difference? What about the gap in the extraction socket? Do we graft or don't we graft around immediate loading settings? Is there a contraindication? Do we use digitally guided implant placement or not? Is it absolutely necessary? How much does it give us? All of these factors come into play as new knowledge of biologically, biomechanically, and certainly new digital technology comes into play. For us, this started playing out, as you see here, in the early 2000s. A case in the maxilla, very excellent ridge, good keratinized tissue. And for this patient, we still go through the same protocols we do for any edentulous patient. Record bases, occlusal rims are fabricated, a full wax-up is done at the vertical dimension that's chosen. And this wax-up is utilized for many things, to create a imaging stent, a radio-opaque imaging stent. We also utilize it to fabricate a provisional stent to be utilized for the immediate provisional, as you see in the lower part of the center of your screen. Now, initially, most of the imaging technology was utilized to help choose virtual implant placement. But in fact, later on, we started to utilize this technology to also help us in the restorative phase of treatment as well. We can see that this is transferred to the virtual image of the maxilla, the wax-up is, and we can then utilize it to align our implants into place, as you can see here. And in many ways, we can look in different angles. We send this information out, and this was Simplant, and we send it out to Materialize, who sends us back a stereolithic model of the arch we're working on, and several surgical stents based on the different drill sizes. Again, this was the initial generation of imaging and guided implant placement. We were able to use that information, though, in the laboratory to clinically place analogs and abutments in place that could start guide us of where the implants would be, what the path of insertion would be necessary, and how and whether we need different types of abutments that could be fabricated. What's the distance between the implants? All of this could be verified even before the surgical visit for the patient. So when we look at all of these and understand, I think it's become very clear early on that we can then utilize this technology and will be transferred over time, given the right transitional information, to CAD/CAM technology that would be possible to, in fact, fabricate CAD/CAM abutments even before the implants are put into place, and we'll show examples of that a little bit later. For this patient, all of this information is taken. All the abutments are chosen, all the implants are chosen, and on the day of surgery, we can just go in. We have our stent. We can do crestal incisions. These stents that were ordered were to be placed directly on the bone, and they were stable, but they had to be held in place. They were not screwed in. This, again, the first generation of these stents. You can see they were actually quite stable in place, and we can go through the series of drills, the 2 millimeter pilot, 3 millimeters, depending on the diameter of the final implants to be placed. You can see the implants are placed initially, and then you can even verify this utilizing the temporary stent that was fabricated, make sure we're right on track, and go back in and increase the size of the drills until we get to the final drills. And then the implants are placed. You can see these were Xive implants from Dentsply. These are the temp abutments, which also act as the implant carriers, drivers, if you will. All the implants are placed. We're looking at the distance between implants, verifying that's exactly as it was on the virtual treatment that we did. And you can see we placed quite a bit of implants. This particular patient request was for single units in the anterior, unsplinted. So we had to place enough implants to actually get her wish. Look at the comparison between the preclinical model on the left, the laboratory model, as well as the one that was actually effectively performed clinically. Very, very similar. We were able to really get everything that we wanted. We already knew we were going to utilize angulated abutments, so the carriers were removed, angulated abutments placed. We go to the provisional stent, and in fact, as you can see, exactly as it was planned on the articulator, it went right over the abutments. The challenge for us, and this is something I'd really like to share with you out there, how do you relate the two? How do you make it really easy and efficient clinically to relate the provisional to the abutments and make sure you have excellent margins? And to do this, what we did is we created acrylic copings fabricated in the laboratory ahead of time, since we already knew what abutments we were using. This was done with acrylic, so that when we went in the mouth and we had the stent is being placed, as you can see here. It has a pallet so that it can be stabilized and verified with the patient's occlusion at the vertical dimension, while the copings are related to the provisional restoration. The bite would be utilized to make sure the relationship is accurate. How do we make these copings? Very simply. And again, this is utilized for single units or multiple units. We take an abutment, seal off the access hole. We use Barricade, Vaseline the abutments, and then powder and liquid acrylic. It's placed. Make sure it's just dab it on, make sure it's very thin, but we have a good, accurate margin. Dip it in some hot water and we have an abutment. All of this is done by either your assistant or your lab. Very simple, very easy. We have very good fit, excellent retention on these, and excellent margins. So when you reline, you're actually not relining to pick up margins. You're relining just to connect the acrylic copings to the provisional restoration, as you can see here. When this comes out, all we do now, again, is just fill in the voids, sharpen the margins, and we have a very, very accurate, immediately accessible provisional restoration, as you see on the right part of your screen. Again, this is how it comes out. We just remove the pallet, fill in the voids, and end up with a very, very nice, very efficient full arch provisional fixed restoration, as you see here. Some 8 to 12 weeks later, look at the healing around the soft tissue. It's quite excellent. All implants osseointegrated. Obviously, we have quite the stability from this kind of splinting. We go through our metal try-in, and the patient, in fact, was able to receive single units in the anterior, splinted in the posterior. But this was a protocol that works out very well. It's a bit of an indirect protocol. Where are we today in these applications? We're able to actually now look at arches like this, and instead of a single scan, in this case I want to thank and a shout out to Max Cohen here in Atlanta for his help in allowing us to utilize this case. We have a full maxilla, And we go through the same protocol you just saw in the previous case. We go through our virtual treatment planning. We fabricate our imaging stent. We place our implants virtually, but at the same time we use the imaging stent to also scan the patient's model. And so now we call this dual scanning. You're scanning the patient, you're scanning the model. You bring the two together utilizing fixed points of reference that's included. And in fact, from that, you can get back, in this case from Materialise, what they call the dental immediate smile model. It's actually a model where you can engage implant analogs at the position that you actually treatment plan on the software. And in fact, you can also get a soft tissue model. This is information that you can now mount and utilize to fabricate your provisional restoration and to really have all the information ready before the patient comes into play. You saw how we did it in the previous patient. This is how Max Cohn did it for this patient. And you can see how it's related in the same way, but you have even more information. Your implant analogs are in a more accurate environment. These are mounted. The bite registration is then taken to stabilize and the upper stent, so that when you take it to the mouth, you will be able to stabilize it in exactly the same position that it was on the articulated model. You can see initially the stent is placed just to verify position, go in with a tissue punch, expose the areas that the implants will be placed in, as you can see on the right part of your screen, and then utilize that bite that I mentioned just previously to stabilize the upper stent in place, and then use fixation screws to make sure that that stent is exactly in that position and that won't move during the surgical procedure. Once that's in place, we can go ahead and utilizing guides for the different drill sizes, we can then go through the drilling sequence, put in our implants, put in our abutments, and get the exact implant position, abutment position than we had on the treatment plan. For full arch restorations, these are really great, very, very viable, certainly the way to go eventually, even as I mentioned, to CAD/CAM related issues. The challenge, of course, these kinds of cases are usually not the really challenging aesthetic cases in many instances. They have long contacts, long teeth. The challenges, of course, are when we're trying to apply immediate loading or immediate provisionalization in that high smile line patient, in that single unit in the anterior. How we do that, how we actually transfer that is really the key. In bringing it all together, with the time remaining, I'd like to share with you what we do today and how that evolved. In fact, here's a case of drilling out an ankylosed tooth. This was a protocol that we published, our team in Atlanta, myself, my brother Maurice, and David Garber published in the year 2000, drilling out ankylosed teeth utilizing root-shaped drills to create a bleeding surface and to make sure we protect the labial plate. Once the tooth is removed, we then go ahead and we'll place in the implant. This happens to be a Xive implant, again Dentsply, early generation. And the implant is placed. We take a stability measurement, very, very key. In our practice, we do measure stability in many different ways. We use the Ostel system. This was the first generation. There's now wireless Ostel. We also utilize a surgical drill. And one of the cutoff, arbitrarily maybe, but it seems to be clinically relevant, is a cutoff of 40 Newton centimeters of stability, of counter torque. If we have more than 40 Newton centimeters, we go ahead and, if necessary, if patient management issues dictate, we'll go ahead and utilize an immediate loading protocol, as you see here. We'll use the acrylic coping I just discussed with you earlier. So you saw it with, for a full arch, you're looking at it for a single unit. I know now I have my margin set. I don't have to worry about the margins. I can take a regular crown former, reline it just to relate the coping to the crown former. We can take a shade guide on the day of surgery, and all the information that's necessary now to go back and fabricate the final restoration is taken. This is where technology is really becomes a tool that can help us to facilitate a more efficient approach to what we're doing clinically. There's the provisional, placed immediately. And what we want, and always for the single unit as opposed to full arch cases, we make sure that these restorations are out of occlusion, both in centric occlusion as well as in excursive movements. We put the finger there to make sure that we feel nothing when the patient goes into excursions. This is about 8 to 10 weeks later. The case was sent to the laboratory. Look at the soft tissue healing around the temporary. We can then remove the temporary abutment and place the final abutment that was fabricated in the laboratory. Excellent soft tissue healing. You see this is an angulated abutment. And put into place, and again, very, very nice healing. So again, utilizing all the protocols that's available. The big key, the big challenge for us, of course, is to make sure that in the single unit now, the aesthetics become very, very paramount. We have a lot more riding on this, a lot more risk for our patients as opposed to, of course, the fully edentulous patients. So for that, we've had to add other factors to our protocols. Single unit external resorption. Today, our protocol really, whenever possible, is include imaging technology, as you've seen, both to direct our implant positioning more precisely, as well as prepare for the restorative aspect of treatment. Predominantly in type 1 sites as this, to preserve everything, we use minimally invasive techniques. That means flapless, atraumatic extraction. We always graft the gap in the socket because we're always looking at managing interfaces, and that's really the big key issue. From an immediate loading perspective, another component is what kind of implant do we want to use? What kind of thread design? What would least stress that bone implant interface? In this case, what you're looking at is an ankylosing implant being placed. A straight abutment is on there. This is a temporary abutment. But how do we handle interfaces? That really becomes the key issue. Now we're combining immediate provisionalization with aesthetic requirements, and interfaces play a big role. And in our practice, we look at interfaces in 3 groups. We call it the tri-zone interface management efforts. We, of course, have the bone zone, if you will. That's where the implant interacts with the bone. And even in the bone zone, there are 2 areas in an extraction socket. There's an area on the palatal where the implant is in direct contact with the bone, and in fact will heal with what we call contact osteogenesis. This is different than the labial surface of the implant that faces the labial plate, that faces the gap in the socket, and in this area, this will heal with distance osteogenesis, and that's where jumping distance becomes a key factor because we need to be able to manage the interface by stabilizing the clot, so the microgeometry of the implant surface becomes key in stabilizing the fibrin clot and allowing for the osteoblast to traverse that distance. In addition, what other critical factors? The second zone that's critical is the transition zone, where you're transitioning from the implant to the abutment. That connection becomes very critical. In implant dentistry, the benefits of platform switching certainly has been shown to be very, very critical. It allows for a greater distance between any gap, even in a rigid connection as you have with this implant system, to tissue that may be influenced by it, which would be the surrounding bone. And then eventually to the final zone, the soft tissue zone. That's the subgingival soft tissue area where the emergence profile plays a big role and is key from an aesthetic standpoint, our ability to really protect that area. So interface development as clinicians becomes very, very critical in what we do and how we end up with the results that we're looking for. The factors is, our job is to be able to take a patient in the most efficient way from what you see on the left part of the screen to the right part of the screen. Usually with a single surgery in an immediate provisionalization, as long as we can get good initial primary stability, either through the palatal bone you see on the screen or the apical bone, and that stability will counteract 40 Newton centimeters of torque, or will be greater than a 60 measurement, 65 measurement on the ISQ of the Osstell system, the implant stability quotient, then we would deem it possible to go ahead and try immediate provisionalization, as long as we can protect that provisional from occlusal forces, eccentric and in excursive movements. So what we're really looking for, and what we have to really continue to challenge is what protocols we can utilize for single units that allow for long-term stability of our results. Not only osseointegration, but that crestal bone, that soft tissue zone becomes very, very critical. Today, as the trends continue to improve, we're utilizing and trying to bring in as many technologies as possible. This is a case in front of you of a patient that has a fractured root. You can see the lesion on the mesial of the left central incisor. And the critical aspect for this patient, for me, is whether that labial plate is intact. If it's intact under our clinical definition in our practice, it would make it a type 1 site. We place our implants and design our treatment digitally, as you see in front of you. I want the labial surface of the implant to be at least 2 millimeters from the outside bone. And we then send this information out, get back a surgical stent. I have the laboratory technician place a laboratory analog, implant analog in either a stone model or stereolithic model, and then finalize and decide on a final abutment so that I can place the final abutment at the time of implant placement. As opposed to previously, in the last few cases you've seen, we were utilizing temporary abutments. We've moved on now to where we want final abutments to be placed at the time of surgery whenever possible. It's not always possible. It's not always efficient to do it that way, but whenever possible, if we can get that information digitally, give it to the laboratory, they can fabricate the final abutment, they can fabricate a provisional restoration. You can see here we're using Radica. It's a very nice composite to fabricate a very nice provisional restoration. So when we go now to the clinic to see the patient, we're able to extract the tooth, place the implant, put in the final abutment, and put in a provisional restoration that same day. And that final abutment usually never has to be removed again, which creates a much better, more stable environment for us to work in. How does that play out? You can see here the stereolithic model is utilized for this patient. The tooth is extracted. We had sent out the digital information to create the surgical stent to help guide us. After tooth extraction, very, very critical from a soft tissue perspective, is you have something that looks similar to what you see on this dog specimen from an article by Colvani. You have a gap on the labial. Well, in our practice, we graft the gap. But we also know that that bone will remodel and will lose some buccolingual dimensions. Grafting the gap will help minimize any changes in that dimension. But also, to ensure that the dimension and the color and the soft tissue parameters are effective, we also, in critical cases, want to put in a soft tissue graft in that area above the periosteum on the labial. In partial thickness dissection, we actually sneak in a subconnective tissue graft in that area, and this has been shown by Uli Grunder in a paper recently published in 2011 in the International Journal of Periodontics and Restorative Dentistry. The group at Loma Linda has done the same thing. Our group in Atlanta certainly has done similar factors. So what we like to do is do partial thickness dissection, get a connective tissue graft to get in there and to thicken that tissue to hopefully more than 2 millimeters, which shows a very stable environment to be maintained. So bone grafting inside the gap, soft tissue grafting above the periosteum on the labial of the labial bone. You can see the implant is placed. The driver is removed, the carrier is removed, and then the final abutment, in this case a zirconium abutment, is placed. We call this concept one abutment, one time, first discussed in 2001, and we then place the provisional restoration out of occlusion. How does this look clinically? You'll see this on the right part of your screen. What we come to the clinical chair with is a final abutment, a provisional restoration, a surgical guide. We use the surgical guide to guide our implant placement. In this case, a Xive implant, 4.5 millimeter in diameter. That's placed in there. We graft the buccal, put in a soft tissue graft as you've seen, and then have the temporary that was prefabricated put in. Here's the healing. About 8 to 10 weeks later, we've managed to maintain the color, the shape, the root eminence of the soft tissue in that area. Good soft tissue healing. We don't want to remove the abutment. I don't want to pack cords, so I have from the laboratory, usually on a die that was fabricated, refractory die fabricated from the abutment at the time of its fabrication. The laboratory fabricates for me a transfer coping with a retentive element, so then I don't have to remove that abutment. We can just take our impression. Again, one abutment, one time means we don't remove the abutment. We keep that initial abutment in place. It allows for that tissue integrity not to be traumatized and maintained. And then eventually subgingival contour is either flat or concave, allowing for less stress on the soft tissue. And then certainly going to the final restoration, we can see that from the initial on the left of extraction, and that's the initial temporary place on the day of extraction and implant placement, and the final restoration on the right, we're able to actually maintain that relationship throughout, and at least preserve, if not augment, at least preserve what the patient had walked in there with. So these protocols, you've seen techniques both for full arch restorations and certainly for single units. The great thing today is that many implant systems are making it possible for us and allowing us to have contoured abutments where we have excellent contour of the abutment subgingivally as well as gingival abutment margins. So we can have anatomic abutments prefabricated, off the shelf if you will. Rather than have the laboratory do it, we can actually put in our implant, take a contoured abutment, in this case zirconium abutment, with a contoured margin, and immediately after implant placement go in and put in the abutment. You can see, look at how it follows the margin of the soft tissue. Again, this is a machined abutment off the shelf, and as it's pushed in subgingivally, we have nice contour. You can see it on the right part of your screen. And we can put in that abutment, prepare the occlusal, and literally have a very, very nice relationship that can then be taken without ever having to remove the abutment. So it's a very, very exciting time for us under these applications. The platform switch environment that you see in front of you not only is very, very good from a tissue relationship level, by shifting the position of the gap more palatally, if you will, you're actually allowing for a thicker region of soft tissue. It's an added benefit to the process. Instead of an implant abutment that connects with the implant at the tangent or at the surface, by connecting with it more towards the middle of the implant, you're actually creating thicker tissue possibilities that allow for a long-term stability of the implant soft tissue restorative environment. I think those are very critical aspects that today we're combining a lot of these techniques together to create what we all want. Is really an environment that is stable over a long period of time, that can be delivered to the patient in a very efficient fashion, and that allows us certainly all the goals that we want. Minimally invasive techniques, efficient clinical protocols, ending up with a very, very stable environment for the long term, especially not only soft tissue health, but also an aesthetic result that we all desire. And you can see this at the time of cementation on the left, with grafting, and then eventually as remodeling, and 6 years later the bone is still above the head of the implants. Certainly a very, very stable environment indeed. And there's a lot of research coming out, certainly that I believe as the surface technology continues to develop and evolve, and we carry this surface technology of the implants onto the abutments themselves. You can see, as Vang shows in Clinical Oral Implant Research in 2008, that in fact not only can you get osseointegration onto the shoulder of the implant, in fact you can get osseointegration onto the abutment itself, as long as that abutment is not taken in and out. Again, that concept of one abutment, one time. Very exciting time to really start to bring a lot of these clinical protocols together. So from biomechanical consideration of immediate loading, as I summarize this discussion, really for a clinician we need to think in terms of interfaces. We need to think in terms of what's going on at the bone implant interface, what is the role of primary stability, how we can increase it by the macro geometry of the implant, by the thread design, if you will, how we can increase secondary stability through, in fact, surface treatment that may allow for faster development of that bone to implant contact to increase secondary stability, thereby increasing and improving cumulative stability, allowing us to immediately load safely, less risk. Contact and distance osteogenesis, factor that into play. If you have a very large socket and very narrow implant that doesn't actually come into contact with some of the side walls of the socket, that may be an area of risk. Implant design, surface microgeometry affects everything you see on the left part of the screen. Those are very critical components. Clinical applications, I've tried to show several different ones for you, from standard low-tech environment, as you saw of the implant research I was involved in, to very advanced digitally guided protocols. And clinical logistics, how we can actually make it possible to have the final abutment, the final provisional fabricated and ready. So if you're just doing the surgery and the patient doesn't want to go back and forth between the surgeon and restorative dentist, the surgeon has access to a lot of these components. He can just place the implant, have the abutment, have the provisional ready in all of this consideration. So to summarize, always think about interface development. Always think about the bone. Think about the transitional zone that's there. Think about the subgingival zone. Utilize protocols that allow you to manage these in a safe and aesthetic environment. It's a great pleasure to spend this hour with you on Dental XP. I look forward to many more like this. And I ask you, if you have any questions, please post them on the forum. I will be looking out for them, and I will certainly try to answer all of your questions. All the best. Thanks a lot. Thank you.